So with that, I will pass it over to Dr. Jane, who is our immediate past president, now chair, now the terms changed, who is the MC for the evening. And I'll see if I can reach out to people and make sure everyone got links who needed them. So I turn it over to the Dr. Jane.
Awesome. Hi, guys. Welcome. So let's go back to this. So just to give you guys a little bit of background, this is, something that we've been talking about since we started the section, essentially. It's been like, 3-4 years now since we've had this section. And we really wanted to make sure that it wasn't just about, critical care topics or the politics of it or any of those things, but really about, that's part of it, but also education. And then also how do we help our section members advance as well? And a big part of that is public speaking, is sort of we want you guys to do that. And the pitch on there is the Speakers Bureau, and that's something that we've started a couple of years ago, and it's still a work in progress. But the idea that we want to create this compendium of critical care speakers so that when someone is looking for a critical care speaker, they can come to this list and say, I know that Andrew is really good at LVADs, so maybe he can come and give us a talk at our grand rounds or just at our resident conference or whatever our local needs are, but sort of having this list. But so part of that is also making sure that people know what they're getting, and we want to make sure that we provide an opportunity to record your talk so that when someone comes in and says, I want to ask Andrew to come and give a talk, what kind of a speaker is Andrew? Is he eloquent? Does he fumble? Does he know what he's talking about? Stuff like that. And part of that is really having a recording up. So this hopefully provides some opportunity for our younger members to do that and to start getting their feet wet and combine that with education. So that's sort of how tonight came out. And so with that, I want to get started. So the format for tonight is going to be, this is our lineup. And then again, our format's going to be 7 minutes with a few minutes for questions afterwards. And then after, we're all said and done, we can always open up discussion for other things as well once all of our participants have gone forward. Just as a disclaimer, this is recorded. Again, that was the whole point, or not one of the many points of this. So this is recorded. And with that, just make sure that you guys everyone else is muted. And with that, I will let Dr. Modilewski take over.
All right, well, thank you very much for having me. My name is Paul Modilewski. I'm an emergency physician and intensivist with the UPMC Pinnacle Health System in Harrisburg, Pennsylvania. So today I have no relevant disclosures. Now, I don't know if anybody has noticed, but there is somewhat of a pandemic going on right now. And it unfortunately does not look like it's going to be going anywhere anytime soon. So as our hospitals are becoming more and more congested, it's increasingly reliant on the emergency physician to manage these critically ill patients that invariably end up staying in the emergency time. So I thought it good to answer one of the questions that I end up getting frequently. What are we doing up in the ICU when it comes to the management of ARDS in the modern era? So just to review our definition of ARDS, we mean bilateral alveolar infiltrates presumed to not be due to volume overload and is quantified by a PaO2 to FiO2 ratio, with lower ratios indicating worsening severity of disease. Now, unfortunately for the disease process, but fortunately for our cognitive space, a lot of the therapies that have been investigated for ARDS have not really panned out. So there's only a few evidence-based interventions that we're going to focus on this evening. Overall, the theme of these interventions is the concept of not making a bad situation worse. We know that when we put somebody on a ventilator, we have the potential of causing further injury to an already sick set of lungs. So anything we can do to minimize that is only going to benefit the patients down the line. So the first main topic, and the one that everyone is probably the most familiar with, is the concept of low tidal volume ventilation. Now, we have known since the early 2000s and the landmark ARDSNet trial that lower tidal volumes are going to be associated with better outcomes. And why is it so critical to make sure we get these tidal volumes right? Well, because we know that these three individuals should not be getting the same tidal volumes. They all have very different lung sizes. And that's why when we're doing this, we're taking into account not a patient's body weight, but their ideal weight, which is related to their sex and their height. So for our average intubated patient, this translates to not wanting a higher than 8 cc per kilogram of ideal body weight. And for our ARDS patients, we're going even lower, even more protective, to 6 cc per kilogram. Once we've dialed in that tidal volume, next thing we're flipping to is looking at our plateau pressures. And what are we driving for? We're hitting that inspiratory hold button. Anyone can do this. And then we're looking to see what is that end alveolar or plateau pressure. What is that pressure that those alveoli are sensing at the end of the breath delivery? And our goal for that plateau pressure is going to be less than 30. Finally, we're going to take into account the patient's pH as well. And this is the concept of permissive hypercapnia. We are allowing for respiratory acidosis down to a pH of 7.2. And what's the reason for doing this? Well, we are, again, trying to minimize lung injury. We're saying that we are willing to accept higher CO2 levels and lower pHs if this means that we can get away with lower tidal volumes, lower respiratory rates, and lower pressures overall. So if we have a pH that's higher than that limit of 7.2, and we then check our plateau pressure. We got a plateau pressure that's too high. The easiest thing to do is to bring that tidal volume down. We start at 6 per kilo, we'll move down to 5. We're at 5, we'll move down to 4. If our plateau pressure is already acceptable, I'm dropping the respiratory rate on these patients, because the less repetitive opening and closing of those lungs is going to cause less injury. And we can just repeat this cycle over and over again. All right. Now, once we've dialed in the ventilator settings itself, we're then moving on to appropriate positioning for the patient. So prone positioning has become something that we've been doing more of, especially in the COVID era. So why is it that prone positioning is beneficial? Well, when we're laying on our backs, we have a whole lot of lung zones that are being compressed. They're compressed by the chest wall weight, the weight of the heart, of gravity pulling fluid down. And we're losing all of this posterior lung area. Because we have more lung in the back than in the front, we end up just ventilating very small areas up front when the rest of it is atelectatic. So we flip somebody onto their bellies, we take that chest wall weight, that heart weight off of the patient, we allow gravity to shift things around, and we can recruit open those additional lung zones that were previously closed. And what we hope to do with this, and what we can show here in imaging form, is that once we've gone through this proning process, we actually maintain those gains when the patient gets supinated again. And the evidence is definitely out there that in not just COVID, but in ARDS in general, that we get substantial, not just benefits in oxygenation, but benefits in mortality as well. So once we have and that's something that does not require the ICU, does not require specialized equipment. This can be done in the emergency department and takes a little bit of practice, but there are tutorials out there, such as this one from New England Journal, in which you can teach your respiratory therapists, your nurses, your techs, and your fellow physicians how to get this done wherever the patient may be. So once we have our ventilator and our positioning set up, we're moving on to the 1 or 2 medications that are going to come up in the ARDS So the use of steroids is something that's really gone back and forth over the years. But what we've come to the decision is that the most recent literature seems to support its use. We're hoping that we're getting this anti-inflammatory effect and suppressing lung inflammation that comes about from this disease process. So the use of steroids in severe ARDS in general is probably indicated. And fortunately, in the COVID era, we're giving steroids to the majority of our patients by the time they get to this point anyway. The other drug type that comes about when we're talking about ARDS is the use of paralytics. Something else that's kind of gone back and forth, most recent literature seems to support that routinely using paralytics in the ARDS patient is probably not indicated or beneficial, although it may be considered when we have high levels of ventilator desynchrony despite adequate sedation. So just summing it up one more time, we're focused on low tidal volume ventilation, keeping our plateau pressure low, allowing for that permissive hypercapnia, prone your patients early and often, steroids for now, paralytics not so much. And thank you for having me here.
That was great. Thank you. Thanks, Paul. Perfect timing too. Fantastic.
Practice that.
I'm going to open up to questions. If anyone has any. Let me see if I can unmute everybody. Unmute all. Anyone has any questions, by all means. I think I see some hands up.
Both have hands up. Go ahead, Skylar.
We both, we put our hands up.
Love it.
Using Zoom. It's great. Hey, Paul, great talk. I love talking about ARDS management and thinking about it too. I wonder, one thing I struggle with, and when some of my colleagues that are emergency physicians ask me about PEEP management. So what is your recommendation on PEEP and titrating PEEP in ARDS, particularly in the early setting, shortly after intubation in the emergency department?
Sure. Yeah, so certainly seems like the majority of patients require, or especially the COVID patients, benefit from some degree of PEEP itself. In people who are not necessarily comfortable with advanced methods of titration, I'll refer them to the low PEEP table from ARDSNet. I think is a pretty safe way to sort of start to titrate things up. If we're able to kind of delve a little bit more into the weeds of ventilator management, I do like assessing the driving pressure and the stress index as well. I think has its place in sort of assessing where you are on that compliance curve, if that additional PEEP is getting your benefit. And then certainly also, if you do end up proning your patients, you really got to assess once they're proned, is your PEEP still adequate, or have you opened up enough lung zones, or have the potential to open up enough that you have to reevaluate your PEEP titration again?
Yeah, great. I like using the driving pressure too. It's just so nice to get at the bedside. It's a nice convenient measurement and makes sense to me as it changes with ventilator adjustments. So yeah, my strategy is very similar. I love it.
Hey, Paul, it's Armin. Great talk. I think a lot of very valid, good points have been brought up by you, and obviously clearly evidence-based. I think I do want to, put in a little bit more of a plug to the paralytic concept. I think, as you know, getting a plateau and getting a reliable plateau is very important to put yourself into a certain box, right? Whether you're using driving pressure to do customized patient-specific lung ventilation, or knowing it in itself the limitations of a plateau, right? The 30 in itself has a little bit of a limit, and let's be very clear. I mean, proning helps. Proning is great. Proning is done very often in the ICU, but proning logistically in the emergency department can be a nightmare, right? One of the biggest problems with proning, as you may or may not know, is just the morbidity of it, let alone the mortality of it, right? Accidental tube disconnection now more than ever in a pandemic can put so many people at risk. So I think I would just say that paralytics for everyone and all comers in the continuous infusion fashion that your study that you presented looked at is probably not the right thing. But I think in the early situation where you're doing PEEP titrations, understanding what is and is not recruitable in your patient, I think I would advise, or I've used and I've found very helpful, that paralytic really allows you to understand the dynamics and both the static and dynamic compliance of the system, but also to really do things like recruitment maneuvers, or really understanding if you have recruitable lung to begin with. And so I would just put a plug in again for paralytics aren't completely meh in my book.
As far as now, absolutely agree. I've used more paralytics in the past 9-10 months than I ever would have imagined for these patients. Certainly when I'm finding that despite, especially the younger COVID patients, despite 2-3 sedative analgesic infusions, I'm seeing a lot of ventilator dysynchrony that, aside from the numbers looking bad and being concerned from that standpoint, I'm really concerned that they are causing additional ventilator-induced lung injury when they're doing these double triggers or kind of generating these huge pulls and pulling out of ideal tidal volumes. So certainly agree. I didn't mean to downplay the use of paralytics that much. More just, I remember from when I was early in residency, I think we had been taught that you meet ARDS criteria, you instantly get a paralytic infusion for X amount of time, no question. That's just part of the routine. Just sort of backing away that in the right patient, it's not necessarily that we have to use it in all patients. It's not the automatic, but
No,
it absolutely has its role.
And that's very true. I sort of found it for initially when this sort of, you can prone someone without a paralytic, it seemed almost barbaric to me. But yeah, now that I've seen it happen, it's certainly doable, and it certainly works. So good talk.
Great job. Thanks, Paul. I want to keep things moving. So Yi is going to be next. You should be able to take it away and share your screen. And then I'll give you the 1 minute warning in the chat.
Sweet. Thank you, Dr. Day. I'm just going to share my screen right here real quick. Can you guys see it? Okay, perfect. I don't know. There we go. Okay. All right. I just realized that I'm the only resident over here, but I'm so glad to be here and share some thoughts on the critical sedation and non-invasive ventilation patient, and discuss about the the evidence we have currently, and what is quote the best agent for everyone. So I'm currently PGY3 at the University of North Carolina, Chapel Hill. I have no disclosure. So I will start this presentation by case. Hypothetically, this is the 18-year-old female, history of autism, morbid obese, and present to your emergency department for respiratory distress. Vitals showed a little bit febrile, a little bit tachycardia, but blood pressure is okay, a little bit tachypnea, but apparently hypoxia on 6 liters. So you got to escalate some care. Patient dyspneic and also very agitated, unfortunately. So it kind of looks like a tough case. This is a chest X-ray. Looks like a little bit infiltrated bilaterally, no pneumothorax. Pneumothorax looks like a medical patient. So the patient, unfortunately, is unable to tolerate high flow nasal cannula or BiPAP. Just keep pulling the mask off and keep pulling the cannula off, which is a nightmare always. And would desaturate quickly if agitated, but able to maintain her SAT when the mom is holding the non-rebreather mask in front of her while she's watching the SpongeBob. That's a good thing. So the decision was made to give patient 2.5 milligram IV Heldo followed by 0.5 milligram IV lorazepam. And unfortunately, there's no improvement of mental status. She unfortunately underwent the hypoxia arrest due to the intolerance of non-invasive ventilation, and got a ROSC, intubated, and admitted to ICU for post-ROSC care. So, this thing happens sometimes in our year, hypoxia is bad, and agitated is bad, and hypoxia plus agitation is never a good combination. What could I have done better? Retrospectively, right? So, the best agent in this situation for sedation, your goal is to avoid intubation for those group of patients. You want to give the patient a chance to tolerate the non-invasive ventilation so that they can transition peacefully from your ER to ICU upstairs, and they can, do whatever they need upstairs. And you want adequate sedation. You want your patient to be able to breathe, right? You don't want to knock them out completely so that they will stop breathing. You have to put a tube over there, which is against your goal. And at the same time, you don't want to cause other problems like hemodynamic issues, QT, allergies, etc. So, a good thing to know is that why are they agitated? There's this article, in 2016 discussing, how to assess patient they have intolerance of non-invasive ventilation. Basically, what they're saying is that you need to find the answer. Try not to use any meds, and if you have to, use meds. That's a short answer. But there are common causes of the reason why patient is agitated on that non-invasive ventilation. If they're just anxious, or if they're just like ear hunger because they're so dyspneic over there, or they're in pain because they have an IV right underneath their butt, or they're simply just unhappy over there. They're not happy with you. They hate you. They don't like you as a doctor, etc. So if you can figure out the reason, that's great. But if you cannot, then you have to sedate them a little bit. So the choice of sedation, this is all the tools we have, right? We have the antipsychotic, we have the benzo, opioids, ketamine, we have the Presidex. Sometimes if you're trained in critical care medicine, of course we have propofol as well, but I'm not going to discuss propofol here because that's apparently not the ideal agent that we would choose. So antipsychotic, I'll discuss the agent we have one by one to review the evidence real quick. So antipsychotics, it's great. It's always reassuring to see that you have the, held in your pocket for any agitated patient. It's a dopamine antagonist. It's a sedative. It can slow, patient's psychomotor activity. Rarely cause respiratory depression, but does prolong QT, and it can cause acute dystonia. Those are the adverse reactions that you don't want to see. But unfortunately, if you read through all the articles, there's actually zero evidence suggesting that of using antipsychotics in facilitating non-invasive ventilation. I just want to point that out real quick because it's a very commonly used drug, but we have zero evidence on that. Benzo, it's great. It's good for anxiety. If you think that your patient is anxious, benzo is a great drug. It binds to the GABA receptors. It has sedative effect only. It can cause respiratory depression and also hypotension very rarely, and it can cause delirium. I know that for all the intensivists over here, you guys probably don't like benzodiazepines at all, but I just want to, put this over here because it's very commonly used in the ER by myself as well. In terms of facilitating an IV, the evidence is actually very limited. There's only one article discussing midazolam and another article discussing about lorazepam. So, it's good for anxiety, but, evidence not good. What about opioids? We use it almost all the time in the ER, all the time in the ICU. It's good for pain. It binds to the opioid receptors, has a sedative and analgesic effect, but it can cause respiratory depression and hypotension. So commonly used that we think that, yeah, it's fine, just give it some morphine. It's the most comfortable drug that we feel to give our patient. But in terms of an IV, whether that's going to help your patient, evidence is also very limited. There's only one article discussing for morphine use in facilitating an IV and zero article about morphine. It's something that you can use, but just keep in mind that the evidence is very limited. What about ketamine? I love ketamine personally as a ER PGY3. Ketamine is a great drug. Everybody loves it. It has a lot of good, agent profile, does not cause any respiratory issue, does not drop your BP theoretically. There's 2 case reports currently, discussing the ketamine use in facilitating an IV. It's just such a special drug that, we just love the profile of respiratory and the hemodynamic effect. And I have to put this photo over here because it's just so special. I want to call it a different name. So I've given him the name of Special K, right? And I love Special K myself. So I put it over here. So the last one is dexmedetomidine. This is a central alpha 2 agonist. A lot of places that if you're not ICU trained, you probably don't have access to it. but it's a really great drug as well as it does not cause any respiratory depression, right? It can cause bradycardia and hypotension. It actually has the best evidence among all the drugs that we just discussed, particularly in pediatric patient population. It's so unique with some caveats that number one, you probably don't have access to it if you're not ICU trained. And number two, you can't bolus. And number three, it's just so slow onset. If you're gonna give IV, you have to wait for a couple of minutes for it to kick in. And it's so unique that I wanted to put another photo over here. I was just Googling on a Google image about Presidex and sedation. This image just popped out. It said it's made in the USA, Presidex and chill, and all the cool tattoos over there. I just feel like, man, this is a drug that can sedate people absolutely. And it's particularly useful for kids. So that's a good one. What about a combination? I give Heldo, I give Advent for that patient. Is that a good combination? Actually, there is an article in 2015 basically saying that number one, it's not a good idea. If you use two or more than one sedative and analgesic agent for this group of patient, it actually associated with a higher chance of NIV failure and also associated with a higher mortality. And I'm not going to read through all the articles, but basically that's the bottom line. So conclusion is there's no single best agent that works for everyone, apparently, because every patient is different. They have different reasons of not able to tolerate the NIV. The existing evidence we have currently is very, very limited. And the best agent is actually the agent that works for your patient. So you have to know your toolbox. You have to know your patient as well. What I would use for this case, if I am ICU trained and ready to roll intensivist, I'll probably do some dexmedetomidine. But if I'm just an ER resident who just work in an ER with my attending, have to hear what my attending want to do, I'll probably do some ketamine. Because nowadays, everybody loves ketamine. My attending probably not gonna, hold against me by using some ketamine on an IV patient. So that's what I would use, dexmedetomidine or ketamine. And thank you very much. That's my presentation.
That was great. Thank you. Lots of food for thought in there.
I will stop share over here so we can go back to that.
Anyone have any thoughts, questions? I mean, I know I do. You're right. I think that when it comes to non-invasive, it's really hard to find one agent that works. I'm pretty sure that I speak for lots of people when I think of elderly, especially. I try my best to not even say the word benzo anywhere near their room, let alone try to even think about giving it to them. The hard part with Presidex, for as much as we all love it and use it like candy, it's hard to get in the ED. I think the only indications that we have in my shop to use them is for peds, for some procedural type stuff, and that's really the only time I can really convince our pharmacists to release it. But it's a great discussion. Anyone else? Anyone have some questions?
I just want to piggyback. A great talk, Yi, and I'm a little biased saying that since if you haven't read the Common Sense article, Yi and I wrote the Common Sense on this. And to your point, Dex is so commonly used upstairs; it's often difficult to get downstairs. And I know the talk was on your NIV sedation, but it's also fantastic for alcohol withdrawal, which sometimes also requires some NIV. But it is, there is, and I think just because it's a medication, it's not used all that often downstairs, but it is a fantastic, and I've found that if I'm consulting and I come down and I do it in the ED, that it's not an issue, and they're open, to trying it. But even if I'm in a shift in the ED, it's still me, right? But there's something about, I don't know, the ICU is coming down to do it, so it's okay, as opposed to, me working in the ED. And I don't know what that difference is, but there's definitely a mentality against it, even though it also is a very helpful drug. I will say that, particularly if people are inexperienced with Dex, it was a while ago that I saw it, but one of the early studies on Dex, up to 10% of people who got Dex ended up getting a little bit of atropine because of the bradycardia. That people, when they were getting used to it, were giving atropine because the heart rate got so low. So, just something to look out for, to tell people to give it a moment, and it'll get better.
I think Alex has a question too.
So actually, I thought my camera is on. Maybe not, but in any case, So first of all, I think it's great that no one's advocating for etomidate. So that's fantastic. The second is that I personally don't see much harm in a one-time dose of a benzo switching to something else. The issue with Precedex, of course, is the speed with which it works. If somebody is much more acute than this person is, Precedex is not going to be your answer, because by the time it would kick in, the event will be over and not well. So I don't know that it's a good agent if you have to intubate someone this second. You can bolus it. There is actually a bolus dose. The one thing I want to comment is there used to be a bottle or a bag that was actually a smaller amount of Precedex that was designed for procedural sedation. And in fact, when I've worked in some other environments where propofol was not available to the emergency department for either political reasons or some nursing board of that state reasons, which means the emergency physician could do it, but the nurse couldn't push it. I used to advise the ED to start using Precedex because it was trade name, it was very expensive, and that would probably get the hospital to release the issue of propofol, which can also be a good agent. So those are a couple of things to consider, and people can argue about my feelings about the one dose of Versed, and then obviously not continuing a drip if it's avoidable, unless of course it's alcohol, someone's suffering from alcohol or benzo withdrawal. But yeah, those are some things that I like to sort of say, and I will lower my hand now.
I think it's also a little bit of, go ahead.
Sorry, go ahead. Go ahead.
I think it's also a little bit of a philosophy thing, right? Like we use a lot of ketamine in the emergency department, but if you flip over to like the ICU, one of the problems I have very frequently is none of the APPs, nursing staff, house staff really know how to titrate appropriately a ketamine infusion. And I think that's perhaps one of the bigger problems with Precedex and the ED is it's the other way around. We do a lot of conscious sedation, but we do a lot of bolus therapy. Precedex as an infusion, I mean, there's a little bit of an art to the titration of an infusion, and that infusion titration practice is just not very germane to emergency medicine. And for example, I mean, you take like your mechanically ventilated patients on propofol and fentanyl. I mean, they're, the patient's agitated and, oh, we've gone from like 20 to 30 of propofol. Yeah, well, that'll act tomorrow, right? You need to do a little bit of a bolus to get that sort of effect and along. So I think great talk, Yi, but like I would say that in your particular case, the only sort of feedback, as it were, to your initial management is I would say that if she's that obese, 2.5 of Haldol and Ativan is probably just underdosing it. You probably need a little higher dose. So you probably were on the right track, and this is the art of medicine than the science of medicine, and why we'll always have jobs, right? So don't self-flagellate too much, but stick with it. There's sometimes a repeat dosing concept and the titration concept that sometimes we just don't have enough time at the bedside to do. But I think you're thinking about it and you're gonna figure it out, because it is indeed patient specific and art specific.
Thank you all for the input. I appreciate it.
Thanks, guys. All right, Gina, I think you're up next.
Awesome.
And then you'll get your 1 minute warning in the chat.
Alrighty. So quick introduction. My name is Gina Hurst. I'm hailing from Detroit, Michigan. I am EMI, I'm critical care, have been working as an emergency medicine doc and a medical intensivist for the past 5 years now. And the goal of my talk today is to talk about the use of the PCO2 gap, or the arteriovenous PCO2 difference in resuscitation. So as an emergency physician or a critical care doc, resuscitation is like bread and butter. This is what we're doing every single day. And our goal with resuscitation is to optimize oxygen delivery and really to restore homeostasis. And we identify our success in that way through our various parameters like SpO2 and lactate, base excess, pH. Our current indices, though, that we have for resuscitation are really based on the optimization of said oxygen delivery. And they really aim to reflect the perfusion of the tissues. they're useful, but they come with their limitations. Studies obviously show that improvement of SVO2 or improvement of lactate can be associated with improvement in morbidity and mortality, but they may be out of phase with the resuscitative efforts that we have, and some of them can be deranged for other organ dysfunctions. SVO2, for example, can just falsely be reassuring at its status of greater than 70% due to impaired oxygen extraction at the microcirculatory level. My goal today, and hope to achieve by the end of this talk, is to accept an additional measurement or parameter called the delta PCO2 or PCO2 gap. In order for us to place the delta PCO2 or the PCO2 gap in our armamentarium as an endpoint for resuscitation, we have to have a basic understanding of PCO2 physiology. Carbon dioxide is within our bloodstream in 3 ways. 10% of it is dissolved in plasma, and the remaining 90% is within the red blood cells, either as carbamino compounds or part of the buffering system as bicarbonate ions. The 3 forms of carbon dioxide are carried then throughout the blood flow and return to the pulmonary circulation and are eliminated by ventilation. The carbon dioxide returns to respiratory surfaces at a rate that's proportional to cardiac output. So we can use our cardiac, or our PCO2 clearance in order to estimate our cardiac output using basically the same thing that we do for Fick equation with oxygenation. Interestingly enough, though, PCO2 dissolves about 20 to 30 times more effectively in our blood than oxygen does, and that diffusibility allows our PaCO2 to be a really good estimate for our oxygen carrying content. And so we can restructure our equation a little bit at a constant. And what we find is that using PCO2 is almost the same as using the oxygen carrying content of carbon dioxide. And it's fairly linear over the physiological range, and even for those that are in some states of shock. You know, the patient that maybe has a baseline PCO2 of 85, 90, this may be a little bit more difficult to interpret, but in a patient who has a normal physiology to begin with, we can utilize this methodology. So given that we can rely on the partial pressure of carbon dioxide, we can use blood gases at the bedside in order to interpret and identify our PCO2 gap. And this will shed light on the resuscitative efforts that we have. The difference between your venous PCO2 and your arterial PCO2 will reflect the balance between the production in the tissues and its elimination in the lungs. And a normal PCO2 gap is anywhere between 4 and 6 millimeters of mercury. So when I'm drawing, this is using your central venous catheter. So when I'm drawing a blood sample from your art line, and I'm drawing a blood sample from your central venous line, there should be no greater than 6 difference in the PCO2. The PCO2 gap greater than 6 is abnormal, and this reflects CO2 stagnation. And this can happen on the macrocirculatory level when a decreased cardiac output leads to accumulation of carbon dioxide in the venous circulation. And this often happens because of decreased pulmonary arterial blood flow. This can happen on the microcirculatory level as well, as carbon dioxide accumulates in the tissues of venous blood, as the venous blood rather produces more than it's able to excrete. Ultimately, what the PCO2 gap does is serve as a marker of impaired perfusion. And you can see this in septic shock. In early shock states, we often see a decrease in our arterial PCO2 as respiratory alkalosis develops, and an increase then will happen in our venous PCO2 as there's stagnation of flow. As the shock state worsens, this gap increases, and then we lead to our typical profile of an elevated PCO2 gap, an elevated lactate, and a low SCVO2. The kicker, though, is that we know that we can have patients that have normal SCVO2s and they're still in severe states of shock. So an individual may not have a may not always have a low SCVO2 and still have hypoperfusion, because an SVO2 is going to be a mix of blood returning to the heart, and some of it can be elevated either due to shunting or due to impaired oxygen extraction. The diffusibility of PCO2 maintains regardless of what's happening in the microcirculation because of that diffusibility we mentioned previously. And so the venous PCO2 gap is still going to be present. Thus, we can use the PCO2 gap in the setting of a normal SCVO2 to aid in the determination of ongoing hypoperfusion. In cardiogenic shock, the PCO2 gap can kind of be a quick and dirty of what is my cardiac index. So if you're in a shop in the ER that you don't have advanced hemodynamic monitoring at that point, you don't have an EV1000 or the capability of doing more than a crude FIC, you can use the PCO2 gap to aid in that. Because they're inversely proportional, if you're seeing a rise in your PCO2 gap, that would suggest that you're having a drop in your cardiac output or your cardiac index. Ultimately, a persistently elevated PCO2 gap is going to be a poor prognostic indicator. It suggests, it's associated with poor hemodynamic parameters, poor tissue perfusion. Patients that have higher PCO2 gaps generally are sicker, they're in the ICU for longer, they're on mechanical vents for longer, and many of them die either in the hospital or soon after their hospitalization. So the question then becomes, how can we utilize or effectively utilize our PCO2 gap? And Dr. Gavelli and his colleagues in France came up with a kind of great little schema that I'm going to present here. And, the right side or the left side of the screen really just talks about our normal oxygenation parameters. If their SVO2 is less than 70, we know how to manage that, improve oxygen delivery. But what happens when a patient's SCVO2 is greater than 70? Well, there's two things that you can do with the delta PCO2. Number one, look at it. If it's normal, great. Normal delta PCO2, normal SVO2, we're banging, your patient's resuscitated, keep it going. If your SCVO2 is elevated and your PCO2 continues to be elevated, then perhaps we need to continue our resuscitation and we're not quite there yet. Either our patient may be more fluid responsive and they need that preload to help increase their perfusion and cardiac output, or they may need some inotropic or chronotropic support in this scenario. Lastly, we can use our delta PCO2 and compare it to the difference in our oxygen arteriovenous carrying content. And this helps us know if there's ongoing anaerobic metabolism. So if I compare my delta PCO2 to the difference between my arteriovenous oxygen content and have a value of greater than 1.4, if that proportion is greater than 1.4, that suggests that I have ongoing anaerobic metabolism, and that the lactate that's still persistently elevated is because I have anaerobic metabolism happening in my system, and that is due to under resuscitation of my patient's shock. And so I need to continue to move through this pathway of determining, do I need to improve my patient's fluid resuscitation? Have I optimized their perfusion to the best of my ability? Ultimately, the PCO2 gap can be used for shock resuscitation either by identifying the ongoing shock and hypoperfusion, evaluating the adequacy of your cardiac output or index, giving some degree of prognostication of the critical illness, as well as determining persistence of anaerobic metabolism and determining the need for ongoing resuscitation. Thank you for your time.
If there aren't any pressing questions, I am respectful of the fact that we are almost at 9 o'clock and we still have one more talk to give. If anyone has a question that it's burning, or by all means.
Sorry, can I ask really quick, does the venous CO2 have to be central, or can it come from a peripheral line?
So it's best when it's central. They did some comparisons of peripheral and central venous oxygenation, and really because you want to look at a mixed PCO2 content, in order to truly say that this is a good delta gap, you're going to want to use a mixed venous sample.
Okay, thanks. I'll shut up now, Ashka. Thanks.
No, it's all good. I think Skylar, you have something really quick. And also Harmon, I know that you have to go. Have a good shift. Go save lives.
No, and it's a really cool topic. I guess how do you find it better than a central venous oxygen saturation? I mean, I guess you get all the information at once. If you're going to do a venous blood gas, you might as well get all the information. But I'm just wondering, do you find you use it differently, or does everything tend to point in the same direction? In other words, is the CO2 gap high and SCVO2 low, or is one lagging behind the other?
So in shock states, what you'll often see is that your SCVO2 will correct before your PCO2 corrects. And so I think that when utilizing the delta PCO2, it's an additional marker of end organ perfusion, and you add it to the milieu of parameters that you have. So I wouldn't exchange one for the other. I would say I have my SVO2. When I've reached an adequate SCVO2, I need to now look at my delta PCO2. So I don't want to be so reassured that my SCVO2 is normal that I'm out of the woods in my shock resuscitation, because if I still have a persistent PCO2 gap, then I'm not at the end of my resuscitation. And to be brief, there was an interesting study where they bled dogs and they actually compared delta PCO2 to SVO2, and your delta PCO2 will track along well with your cardiac index and your restoration of perfusion much better than any of your other parameters, even like lactate, SVO2, all of that. It all lags behind.
Cool. Yeah, I'll start paying more attention to it. Thanks.
Yeah.
Do we have like a human, like in human, like do they, you said that there's like a dog study for it. Is there any like human studies for it?
Oh, there's many human studies, but I don't think they've bled humans.
Hopefully not.
Most of the ones in humans are done in septic shock. There's a couple that are done in cardiogenic shock, and then some like post-cardiotomy or intra-op studies for patients that are put on or off pump.
Gotcha. But there are like tables to show like if your PCO2 gap is this, your cardiac index is this. Very cool.
Yeah.
And with that, Inika, you're up. And so you're welcome to share. Yep, there you go. Oh, you're muted. Let's unmute you. Start again.
Okay. So hi everyone, my name is Inika, and yes, this brief talk is going to be about fluid status. I figured since we've been talking and debating about fluid status for the past 20 years, why not we talk about it for another 7 minutes today? So with that, let's start with a case. So this is a 56-year-old female who came to your emergency department complaining of lower leg pain. She was febrile, a little tachycardic, soft blood pressure, and on examination, you're concerned about possible cellulitis because her right legs are a little redder compared to the left, and it's hot to touch. It looks kind of angry. So as soon as you go back to your computer, you got some blood work back. She has elevated lactate. And then the computer asks you, right, do you want to give this lady 30 cc per kilo fluid bolus for that lactate of 5 if you're thinking about sepsis? Now, fluid status. It's still a hot topic, controversial topic in emergency medicine and critical care. And frankly, no one has figured out the perfect solution yet to assess fluid status accurately. But what we do know is that too much fluid can hurt, and we have data for it. So we all love ultrasound. We can use ultrasound to get individualized care, assessing the fluid tolerance of the patient in front of us. And I think most of us are familiar with the RUSH protocol in evaluation hypotensive patient, right? You assess the pump, you assess the pipes, and you assess the tank. And of course, one of our favorite thing to do is look at the IVC. And at some point, we thought that the IVC would be the ultimate answer to fluid status question. Unfortunately, we know that wasn't the case. So I want to talk to you guys about venous congestion ultrasound. What is it? It's essentially using an ultrasound to see if there's any evidence of organ congestion. thus pointing to the fact that, hey, maybe the patient in front of you is congested and is fluid overloaded. Now, I have to say that this portion of the talk, there's not much data to back it up yet, but in our group, some of our practitioners use it in our daily practice to assess fluid status and fluid tolerance. We are collecting data actively to back up our practice. And again, I think there's a sound physiological reasoning to support this practice. Some caveats, I'm only going to be talking about hepatic vein and portal vein. Some people out there also take a look at the renal artery and renal vein. In my practice, I find it usually harder to get the renal vein and renal artery imaging. And also, we cannot use this if your patient has a primary organ disease like liver disease, liver cirrhosis, for example, or vascular pathology like portal vein thrombosis or hepatic thrombosis. To get the hepatic vein, you can use your right upper quadrant view, just like your FAST exam, or you can use your subxiphoid view, where you see the hepatic vein dumping into the IVC. Once you find the hepatic vein, put your collar Doppler on it, do a spectral wave, pulse wave Doppler to get the hepatic vein wave. A lot of people will say that hepatic vein is mostly triphasic, but it actually has four components. But the big three components are the A wave, the S wave, and the D waves. So your A wave is your atrial kick. This is where some of the blood rush into from the right atrium to the right ventricle, but some will go backwards, flowing into the IVC and then the hepatic vein. Your S wave is your big waves, right? As that tricuspid annulus goes down towards the apex of your heart, it will create a suction effect and have the blood rush from the atrium to the ventricle. And then your D wave is your diastolic. And it kind of looks like similar to your CVP tracing. Now, in normal situation, your systolic waves will always be bigger than your diastolic wave. As you go from a state of congestion, your S wave will go smaller and smaller, and then eventually it will reverse. And in some very congested cases, your A waves will fuse with your systolic wave, creating one big positive deflection and leaving your D wave as the only negative deflection wave. This is a normal hepatic vein pattern. There's an A wave, S wave, and D wave. This one is an example of congestive state where the A wave and S waves are fused together, make that one positive deflection. And your D wave is your diastolic wave, making a solitary negative deflection. Okay, portal vein, similar thing. You can use your right upper quadrant view to find the portal vein. It's near the hepatic vein, but the portal vein will have thicker periphery. In normal condition, your portal vein will have monophasic continuous pattern to it. And as you go to a state of congestion, then you'll start seeing pulsatility and eventually a to and fro pattern suggestive of congestion. This is an example of normal and abnormal. Monophasic continuous pattern is normal, and abnormal pulsatile pattern suggestive of congestion. Going back to your lady, you decide to do your ultrasound, and this is what you see. Flattened septum, big RV, not moving that well, tricuspid regurg, and then you look at her hepatic and portal vein, and you see a pattern of congestion. So if you had automatically click on that yes to 30 cc per kilo fluid bolus, you might have harmed this lady. She forgot to tell you that she has a history of scleroderma and has a chronic RV dysfunction from the pulmonary hypertension secondary to her scleroderma. Okay, so use your ultrasound, assess the pump, the pipes, and the tank, and then up your game when you scan the tank and include your venous congestion. See if there is any evidence of organ congestion. Plum IVC, you just consider if your hepatic vein have evidence of congestion or your polyphane, and then assess whether that patient is fluid tolerant or not. And that's all I have. Thanks.
That was great. I feel like when we talk about fluid status, we still haven't figured out an accurate way, and there's so many more. The way I always describe it is there's more stars in the constellation the more and more we keep doing this, and so it makes the constellation a little bit more obvious the more data points we add to it. I love this. I don't think I ever use this, and I want to start adding it to my constellation.
Yeah, and it's sometimes easier to get the hepatic and portal vein, when someone is, well, we all know in ICU or in the ED, sometimes people just have difficult cardiac window. And it might be easier to go right upper quadrant and find that hepatic or portal vein.
Awesome. Any other questions, comments, thoughts? I know that there was lots of other discussions that sort of got put on hold. By all means, to bring all those back in these last few. Anyone? Bueller?
Dr. Wolf, I just have a quick question about the, how to get that window for the hepatic vein. So do you have to put that that little line in line with the hepatic vein, or is there any like certain angle that you cannot really? Because for example, if you do 90-degree angle, apparently you can't use Doppler on that one. But
Right.
like how in line with that hepatic vein that you would accept to use that in your decision making in terms of fluid resuscitation?
Yeah, for sure. So with any Doppler, the more parallel you get with the blood flow, the better it is. And again, right upper quadrant approach should give you that view that you can put your pulse wave Doppler and get that vein pattern.
Gotcha. So basically, you put it in line with the hepatic vein as much as possible.
Yeah, pretty much. 180.
Gotcha.
This was great, guys. Thank you so much. I can't thank everyone that spoke, as well as all of our attendees. Everyone, thank you. This was a great kickoff for this. And with that, again, I want to be respectful of people's time. I know we went a little over because we were dealing with some technical difficulties. There's a bunch of information in the chat on the side. I am going to save the chat just in case someone is looking for any of that information. Just contact me. And then, of course, this was all recorded, so we'll have access to that eventually as well. And with that, I want to say thank you and good night.